Hello everyone, welcome to SudhirEyeCoach, a channel designed especially for budding ophthalmologists. Whether you are just starting your journey or looking to enhance your skills, this is the place to learn, grow, and share knowledge. Let's dive into the fascinating world of eye care and surgery together. This was a straightforward surgery, and the patient presented with a grade 4 nucleus, so I proceeded to stain the anti-capsule with Trypon blue to enhance the visualization. Typically, I start by creating two side port incisions for instrument access, followed by a main clear corneal incision measuring 2.2 mm. This approach provides optimal entry for phacoemulsification and ensures good control throughout the procedure. I initiated the capsular access with smoothly completed it, ensuring that the size was approximately 5 mm, which is ideal for this type of surgery. And especially in the mature cataract, we need to create the bigger size of capsular access for to get a lesser complications in the during phacoemulsification. I performed a thorough hydrodissection and delineation to effectively separate the nucleus from the surrounding cortex and to free the epinucleal plate from the capsular bag. These maneuvers ensured that the nucleus was mobile and ready for safe phacoemulsification. After making the initial crack in the nucleus, I noticed that it was not rotating as expected. This is typically a red flag suggesting that there might be an issue with the posterior capsule or with the zonules. At this point, recognizing the potential risk, I decided to stop the surgery and plan to shift the case for VR support. Continuing with the phacoemulsification could have led to serious complications given the weak lens, compromised nucleus, and evident zonular weaknesses. Proceeding further might have caused significant posterior capsular issues, so it is very important to stop on time to prioritize the patient's safety and seek specialized assistance. The patient was administered local anesthesia to ensure comfort and achieve proper cooperation during the procedure. This helped to stabilize the situation while making further arrangements for VR support, allowing for a smooth transition without additional strains on the patient's eye. In the situation involving a compromised posterior capsule or zonular weaknesses, the primary challenge for VR surgeon is safely removing the nucleus while minimizing intravitreal manipulations. And this is crucial to reduce the risk of retinal complications. Strategies such as converting to posterior assisted levitation or PAR technique, utilizing a fragmentome for controlled nucleus removal, or supporting the nucleus with anterior vitrectomy can help and ensure a safer outcome while preserving the integrity of remaining ocular structures. In this case, the nucleus was quite hard and nearly the entire nucleus remained intact. Given the circumstances, we decided that the best approach would be to remove the nucleus and the remaining block through scleral tunnel incisions. This method allowed for a more controlled extraction while minimizing the risk of further damage to the posterior capsule and the surrounding structures. A well-sized scleral tunnel incision was carefully designed to facilitate the smooth and the safe removal of the nucleus, ensuring the incision was large enough, minimizing stress on the surrounding tissues and allowed for controlled extraction without causing additional complications. So we created a good size scleral tunnel incision. Since the capsular access was slightly smaller in size, it became necessary to make relaxing incisions on the capsule before attempting to remove the nucleus from the bag. These incisions allowed for better expansions, reducing the risk of tearing the capsule during the extraction of hard nucleus and ensuring a safer procedure. Multiple relaxing incisions were strategically placed in the various areas of the capsule to ensure the smooth and safe removal of the nucleus. Protecting the nucleus endothelium is crucial in such cases. To ensure this, I always fill the antechamber and coat the endothelium with dispersive viscoelastics. This creates a protective barrier, reducing the risk of endothelial cell loss during the manipulation of nucleus and other intraocular maneuvers, thereby preserving the corneal clarity immediately post-operatively. This VR surgery was performed by Dr. Smriti Mishra, who is Senior ER Consultant at Sun Eye Hospital, Lucknow. During the process of nucleus removal, it is generally safer to first pop out the nucleus into the antechamber, moving it out of the capsular bag. This maneuver allows for better control and reduced stress on the posterior capsule before removing the nucleus through the scleral tunnel incision. It helps to prevent further complications, and particularly in the cases with compromised cases or in such case these type of cases. This is the time where endothelium protection remains critical. At this particular stage, it is essential to coat the endothelium multiple times with dispersive viscoelastics to ensure it is well protected during the nucleus manipulations and extraction. With the assistance of wire vectors, the nucleus was carefully planned for removal. The wire vectors helps in stabilizing and guiding the nucleus out of the eye, especially when you are dealing with the hard nucleus or compromised capsule. The nucleus was successfully removed and smoothly removed. Next, it's time to assess the posterior segment for the potential complications and damage. So at this time, the vitrectomy cutter was utilized for the removal of both cortical matter and the remaining fragments of nucleus. Vitrectomy was also performed to remove any vitreous that had entered in the antechamber. This step is crucial to prevent complications and ensure that the antechamber remains clear and free of vitreous traction, which could affect the final outcome of the surgery. Now it is time to examine the vitreous cavity thoroughly. This examination is essential to check for any residual cortical matter or fragments of nucleus lying in the vitreous cavity over the macula. The posterior vitreous detachment of PVD was initiated and the vitreous was carefully removed from the macula. This thorough removal helps to ensure the vitreous does not cause any traction or complications, and it is crucial for maintaining the health of macula and optimizing the overall outcome of surgery. Thorough removal of vitreous cavity from the cortical matter of any fragments of nucleus is crucial. Residual cortical matter or nucleus fragments can lead to floaters and other visual disturbances and potentially causing significant difficulties for the patient in the future. Ensuring complete removal helps to prevent these complications and contributes to a better long-term outcome for the patient. Now it's time to focus on the antechamber. Any residual vitreous or fragments left in the antechamber can lead to further complications such as inflammation, raised intraocular pressure, or damage to the corneal endothelium. Ensuring that the antechamber is completely clear is vital for preventing post-operative issues and promoting smooth recovery. The remnants of capsular bag or tags were carefully removed because any remaining capsule in this area could potentially interfere with the placement of retrovirus claw lenses. By clearing these tags, we ensure that the lens will remain stable and properly positioned, minimizing the risk of dislodgement or other complications. With the antechamber and the vitreous cavity thoroughly cleared, the next step is the implantation of iris claw lens. This step requires precise repositioning to ensure the lens is securely attached to the iris, providing stable visual rehabilitation while minimizing the risk of future dislocation and complications. Iris claw implantation is truly an art for any segment surgeon. It serves as a life saver during complex situations like these. Mastery of this technique can significantly improve patients' outcomes in cases of compromised capsular support, offering a reliable and stable solution when other options might not be feasible. In such situations, scleral fixated IOLs can also be considered as an alternative. However, they require a more intricate technique, often involving suturing or fixation of flanges, which can introduce additional risks such as suture erosion or IOL tilt. The iris claw lenses, by contrast, offers a quicker, more straightforward approach, especially in cases where time and simplicity are crucial, and it provides excellent stability and with fewer complications. Before implanting iris claw lenses, pupil constriction is essential to ensure proper lens attachment to the iris. Constriction provides better visibility and control during implantation. After the lens is securely placed, intracameral miotics are used to maintain pupil constriction, ensuring the lens stays in position and preventing post-operative complications related to the lens movement or dislodgement. At this stage, the antechamber was thoroughly irrigated to remove the traces of viscoelastics, ensuring that no remnants remain that could cause elevated intraocular pressure or other complications. A final assessment of vitreous cavity was also conducted to confirm that no cortical matter or nucleus fragments were left behind, ensuring a clean and stable environment for optical post-operative recovery. Now it's time to place a suture to close the scleral tunnel incision. This is particularly important because the iris becomes flaccid and tends to prolapse through the incision. Securing the tunnel with the suture helps maintain the integrity of the wound and prevents iris prolapse and promotes proper healing, reducing the risk of post-operative complications. With all vitreous entries sealed properly and the structural integrity of the eye confirmed, the surgery is now complete. The eye is stable and all potential risks have been addressed properly. The patient is now ready for post-operative care and recovery with a strong outlook for the successful outcome. So that wraps up today's case. If you have any queries or questions, feel free to leave a comment below. I would do my best to respond personally, and if there are any specific types of surgeries you would like to cover in the future by me, please let me know. Thanks for watching.